Mrs. Bhama Devi, a 55-year-old female with no comorbidities, presented to us with complaints of holocranial headache for the past 1 year. This was severe in intensity, episodic, and progressively worsening. There were no signs of raised ICP, seizures, sensory motor deficits, or cranial nerve involvement. On examination, she had an unremarkable general physical and neurological examination. Her radiology suggested a T1 hypo, a T2 flare hyperintense lesion with no diffusion restriction or susceptibility changes. Her contrast imaging showed a non-contrast enhancing lesion in the right lateral ventricle abutting the septum pellucidum at the level of the foramen of Monro. She was planned for an exoscope plus endoscope assisted resection. The patient was placed in a supine lateral position and a linear incision was marked over the mid parasagittal area. With the help of two burrs, a left parasagittal craniotomy was performed. The bone flap was then carefully elevated. Bone was nibbled in the midline to expose the sinus adequately, which was separated and safeguarded. A U-shaped durotomy was performed and reflected over the superior sagittal sinus. This dura was secured in situ. The arachnoid adhesions in the midline was separated and an interhemispheric approach was sorted to. Dissection was further deepened. The ipsilateral and contralateral cingulate gyri with the pericallosal arteries running over the corpus callosum were identified. At this stage, navigation was used to identify the exact location of the tumor so as to plan the site of the callosotomy. Both the vessels were safeguarded and mobilized to the opposite side. Callosotomy was done and deepened at the pre-marked location. The tumor was identified in the right lateral ventricle. It was grayish, mildly vascular, partly suckable, with a poor plane of cleavage. The tumor tissue was removed piecemeal. The tumor was easily cuseable. A curette was used to mobilize the parts hidden from our view. Here we see the foramen of Munro. After resection, a check endoscopy was performed to identify any hidden bits of the tumor, which were then removed with the help of the endoscope. Finally, after a thorough wash and achieving hemostasis, the tumor bed was found to be clear. This is the final tumor cavity. The dura was closed using proline sutures, and closure was done in layers. This is the post-op scan of the patient. She was extubated on POD 0. She had no new deficits with a normal post-operative scan.